Welcome back to the Deep Dive. This is where we take the dense clinical reports, the detailed research papers, and, well, the specialist guides, and we distill them into the crucial nuggets of knowledge you need to be truly well-informed.
And today we're tackling something that it's incredibly common.
So common, yet it's persistently ignored in so many conversations about midlife health. We're talking about painful sex or clinically dyspareunia.
It is a conversation that desperately needs to be brought into the light because the statistics, they really reflect a huge amount of private suffering.
What are we talking about, numbers-wise?
Well, data from the UK suggests that a notable 7.5% of sexually active women report experiencing painful sex, and that's just within the last year.
Wow, so that is not a marginal problem.
Not at all. It's a major public health issue that deeply impacts relationships, emotional well-being, self-confidence, and it so often goes undiagnosed or, frankly, just dismissed.
Absolutely. And our mission today is to move beyond that generic advice and provide a really structured, comprehensive understanding of this.
Right.
And for that, we've been taking a deep dive into comprehensive sources, drawing heavily on the clinical expertise and detailed guidance from the Women's Health Clinic.
Specifically, the work of Dr. Farzana Khan. Her entire approach emphasizes clear explanations, evidence-based solutions, and crucially, that sense of shared decision-making with the patient.
That holistic view seems essential.
It is. Dyspareunia is rarely a simple infection or a single anatomical issue. In almost every case, it's a complex tapestry. It's woven from hormonal shifts, muscle tension, neurological hypersensitivity, and psychological factors.
And our goal is to untangle that tapestry for you today.
Exactly. We're going to break down the assessment, the numerous causes, the foundational self-care, and then the entire spectrum of specialized treatments available, right up to the latest in regenerative therapies.
Okay, let's unpack this. And the critical first step, which is surprisingly often skipped in, say, standard primary care, is defining the pain.
Yes.
Not all pain is the same.
Yeah.
And identifying its exact location and quality,
Yeah.
That's the diagnostic map we need.
Precisely. For clinicians, that map starts with a crucial, simple bifurcation. We have to separate entry pain from deep pain.
And this distinction, it guides you instantly down two very different investigative pathways.
It does. If we get this wrong at the start, we can spend months, even years, chasing the wrong diagnosis.
Okay, so let's look at entry pain first. This is pain felt right at the opening, the introitus or vestibule. What are the common descriptions that instantly flag this type of pain for you?
Entry pain is immediate, it's superficial, and it's often described with terms like stinging, tearing, burning.
I've heard cut with glass.
Cut with glass is a classic one, or that the tissue is being shredded. It happens upon first contact, or even just light penetration.
So it strongly suggests an issue with the local tissue itself.
Right. Extreme friction, tissue fragility, what we call atrophy, or a nerve hypersensitivity. It's an ouch right now kind of pain.
And how does that contrast sharply with deep pain?
Deep pain is, well, it's felt much higher up. It often radiates into the pelvis, the lower back, or the lower abdomen.
And the feeling is different.
Completely. This usually feels more like aching or throbbing or cramping. This is typically collision pain.
Collision pain.
It's triggered by deep penetration or thrusting, where structures like the cervix, the uterus, or the ligaments supporting the ovaries are being, well, jostled.
So understand that distinction. Superficial friction versus deep collision. That's the cornerstone.
It's the absolute cornerstone of an accurate diagnosis.
That makes perfect sense anatomically. But for the listener, what is the single biggest misdiagnosis you see in clinical practice before this proper diagnostic map is used?
Oh, it's almost always confusing chronic entry pain with recurrent thrush, a yeast infection.
Because of the burning sensation?
Exactly. If the pain is burning or stinging, many women, and sadly many clinicians, they jump straight to antifungal treatments.
But it doesn't work.
Or it only offers very temporary relief. If the swabs keep coming back negative or the treatment isn't lasting, we have to consider other things. Skin conditions, nerve pain like provoked vestibulodynia, these require completely different specialized care.
And that's why the specialist assessment uses that comprehensive biopsychosocial model.
Right.
So let's detail that assessment. It starts with the cornerstone of diagnosis, meticulous history taking. What information is a specialist trying to extract that, a typical 10-minute GP appointment might just miss?
We need granular detail. Beyond just the location, we need the timing.
Timing.
Yeah, does it happen before sex? Is that an anticipatory anxiety? Is it only during penetration? And importantly, does the pain linger for hours after intercourse?
That seems like a key clue.
It's a huge clue. Pain that's a deep ache and only resolves after an hour of lying down. That points very strongly towards muscle spasm or tension in the pelvic floor.
What else?
We need to know if there's a cyclical pattern. Does it get worse with your period? That might suggest endometriosis or adenomyosis. We need the quality sharp, dull throbbing. And we also need to know about associated symptoms. Dryness, discharge, changes in urinary frequency. All these little pieces build the puzzle.
Okay, so after the history, we move to the physical examination, which, and we have to re-emphasize this, is always gentle and completely consent-driven.
Absolutely vital, and it's often not what people fear it will be.
And it seems crucial for confirming the historical data.
It is. The exam starts with just an external inspection of the vulva. We're looking for visible clues, scarring, color changes, any little fissures, or the very distinct white, fragile patches that signal a condition called Lichen sclerosus.
And you're also assessing the tissue integrity itself.
Right. And importantly, if the pain is purely entry pain, a speculum is often entirely unnecessary.
Which I imagine immediately reduces a lot of anxiety for the patient.
A huge amount. They're anticipating this painful procedure, and often we don't even need to do it.
What's the clinical importance of the Q-tip test, and how does that help separate, say, tissue damage from nerve damage?
The Q-tip test or cotton swab test it's a game changer for entry pain.
How does it work?
The clinician uses a gentle, moist cotton swab to just map the sensitivity of the vaginal entrance, specifically the vestibule area.
And what are you looking for?
If we touch the skin and it elicits a painful, sharp burning sensation, but the skin itself looks completely healthy and normal, that strongly suggests provoked vestibulodynia, or PVD.
So it's a nerve hypersensitivity issue.
Exactly. The nerves are misfiring. The test allows us to define the precise borders of that hypersensitive area, which is crucial for targeted treatment, like local nerve blocks or topical medications.
So the Q-tip test handles the superficial pain. But if a patient is experiencing that deep collision pain, you need to assess the internal landscape. How is that done?
That's where the bimanual palpation comes in.
Okay.
With gloved fingers internally and the other hand gently pressing on the abdomen, the clinician can systematically check the size, the mobility, and the tenderness of the pelvic organs. The uterus, the ovaries, the supporting ligaments.
So you're feeling for restrictions or pain points?
Exactly. If there's restricted movement or severe tenderness when moving the uterus, that raises the index of suspicion for conditions like severe endometriosis or pelvic scarring from past infections.
Before confirming those deeper causes, what's the initial testing pathway for ruling out the more acute problems?
We always start with the immediate rule-outs infection. So swabs for things like bacterial vaginosis, candida, which is thrush, and sometimes STIs.
And if those are clear,
if the history or the palpation suggests a structural issue, a transvaginal ultrasound, TVUS, is the next logical step. It's excellent for finding large structural issues like ovarian cysts, uterine fibroids,
which are benign muscle tumors.
Correct, or other masses.
Let's take a moment to define one of those structural issues you mentioned, adenomyosis, because it's mentioned a lot less often than fibroids, but can cause significant deep dyspareunia.
That's an excellent point. It's often overlooked. Fibroids are like discrete, solid lumps of muscle. Adenomyosis is different. It's where the tissue that lines the uterus, the endometrium, actually grows into the muscular wall of the uterus, the myometrium.
So it's like the lining is in the wrong place.
Precisely. This causes the entire uterine wall to thicken, to swell, and become bulky and congested, especially in the lead up to and during a period.
So when the uterus is larger and more congested, deep penetration causes more pressure and collision pain.
Exactly. The patient often describes a deep, generalized cramping and pressure, and it's almost always worse around their period.
And this brings us to that critical clinical caveat, the one that prevents years of diagnostic delay and frustration.
Yes.
A normal ultrasound does not exclude endometriosis.
We have to hammer this point home as per guidance from bodies like NICE in the UK. Endometriosis, especially the superficial form, it's essentially invisible on a standard TVUS. It's like trying to see clear frost on a window.
So what happens if the ultrasound is clear but the symptoms persist?
If the patient has persistent deep pain, particularly if it's cyclical, or if it causes pain with bowel movements or urination, the diagnosis of endometriosis must still be pursued.
How?
Either through targeted hormonal suppression trials to see if suppressing the cycle helps the pain, or advanced imaging like an MRI. We simply cannot rely on a clear ultrasound result to dismiss a patient's symptoms of deep pain.
So we've established the diagnostic process. Now let's turn to the terrain itself, starting with the dominant physical change impacting women in midlife, especially those aged 40 and above.
Hormonal tissue changes.
Here's where it gets really interesting because the cause is often physiological
That's it.
and often very fixable.
We are talking about the genitourinary syndrome of menopause, or GSM. And we must stress that this definition replaced the outdated term vulvovaginal atrophy, or VVA,
Why the name change?
because it encompasses not just the atrophy of the vagina, but also issues with the vulva, the urethra, and the bladder. It's a whole system.
So define GSM for us. Walk us through the precise anatomical mechanism that turns comfortable sex into painful sex.
Okay. GSM is driven by the chronic reduction of estrogen exposure to the genital and urinary tissues. Estrogen is. It's the lifeblood of that tissue.
What does it do specifically?
It maintains the thickness of the vaginal lining, ensuring the cells are plump and layered. Think of it like a plush, resilient carpet. It also supports blood flow, and it encourages the production of glycogen.
And glycogen feeds the good bacteria.
Exactly. It feeds the healthy lactobacillus bacteria, keeping the pH acidic and protective. When estrogen declines, that lining thins. It becomes atrophic. It loses its collagen and its elasticity.
So mechanically, what's happening during sex?
The tissue loses its natural cushioning and its ability to stretch. The superficial layer becomes fragile with fewer protective layers of cells. So when there's friction, even with lubrication, the tissue literally suffers micro tears or micro abrasions.
And that leads to that sensation you mentioned. Tearing, rawness, paper cuts.
Yes, it's a structural breakdown. And no amount of lubricant alone can fix tissue integrity. That's a key point.
The timing here is critical. Most listeners probably associate this with being postmenopausal, but you emphasize that GSM often starts much, much earlier during perimenopause. Why is that?
Because perimenopause, which can start in the early 40s and last for years, is characterized by wildly fluctuating estrogen.
So you still have periods.
You might still be having periods, which leads women and their doctors to assume their hormones are fine. But during periods of significant estrogen dips, the local genital tissue starts to starve.
Even if the periods come back.
Right. That cumulative lack of exposure starts the thinning process. What matters to the vagina isn't the fact that bleeding is still happening, it's the consistent presence of estrogen.
And we often see that specific early warning sign that patients describe as the phantom UTI.
Yes, that is a classic presentation of local estrogen deficiency. The urethra, which is right next to the vaginal entrance, is highly dependent on estrogen.
So when the tissue thins there,
It becomes inflamed and hyperreactive. This mimics a urinary tract infection perfectly. You get urgency, frequency, sometimes burning with urination. But when we send the urine sample to the lab, the cultures come back negative.
so the treatment isn't antibiotics.
The appropriate treatment is local estrogen to restore the tissue health, not repeated courses of antibiotics.
Now, for our younger listeners who might be experiencing these symptoms but are far from midlife, what other conditions can induce a low estrogen state like this?
There are a few key physiological states and medical interventions. One is breastfeeding.
Okay.
The hormone prolactin suppresses estrogen and can cause quite severe, though usually temporary, atrophy and dryness.
And the other big one.
Another major factor is certain types of hormonal contraception, which we'll discuss in more detail later, because they can suppress your body's own estrogen production. And finally, and tragically, cancer treatments, particularly chemotherapy or hormone-blocking medications like tamoxifen or aromatase inhibitors. They induce a state of medically induced menopause, causing profound and sometimes immediate GSM symptoms that need proactive management.
Moving beyond hormonal fragility, let's address conditions where the pain is primarily driven by chronic inflammation and tissue change. These are the ones often mistaken for endless recurrent thrush infections.
This is a vital section because these conditions, lichen sclerosus, LS, and lichen planus, LP, can cause progressive and potentially irreversible architectural damage if they're not caught and treated aggressively early on.
Let's start with lichen sclerosus. How does it present, and what is the consequence for sexual function?
Lichen sclerosus is a chronic inflammatory skin condition. It causes the vulval skin to become pale, white, thin, and fragile. It's sometimes described as cigarette paper skin.
And the inflammation itself causes symptoms.
Yes, severe itching, tearing, and fissuring, especially around the entrance. But the profound long-term consequence is introital stenosis,
Which is
the progressive narrowing and tightening of the vaginal opening due to scar tissue formation. The whole architecture can be altered. The labia minora can shrink and disappear, and the clitoris can become encased in scar tissue, which is called phimosis.
That sounds absolutely devastating. The pain must be intense.
It is often described as a constant burning or a cutting sensation. When penetration is attempted, the fragile skin simply tears, which leads to more scarring and more narrowing. It's a vicious cycle.
And the statistics are pretty stark.
They are. We know from clinical studies that up to 75% of women diagnosed with lichen sclerosus report debilitating dyspareunia.
How does lichen planus, the other major inflammatory condition, differ from that?
Lichen planus is often more aggressive. It can present as painful ulcers and raw, open sores on the vulva. And critically, it can also affect the inside of the vagina.
So it's not just external.
No. When it affects the vagina, it's called erosive lichen planus, and it can lead to something called desquamative vaginitis, where the lining literally sheds or sloughs off. The result is chronic pain, intense burning, and scarring inside as well as out.
Since these conditions lead to permanent scarring, timely and effective treatment is non-negotiable. What is the standard medical intervention?
The cornerstone therapy, the gold standard, is ultra-potent topical steroids, specifically clobetasol propionate.
And this isn't a moisturizer.
Not at all. It's a powerful anti-inflammatory designed to stop the inflammatory process that causes the scarring. The application needs to be very structured.
What does that mean?
It means applied intensively, often daily, for several months to bring the inflammation under control. And then, this is key, it's continued long-term at a lower maintenance dose, maybe twice a week for life.
The fear of using powerful steroids is common, though. What's the practical advice you draw from Dr. Khan's expertise on application and compliance?
It's a valid concern. Patients worry that long-term steroid use will thin the skin, which is true for milder steroids used improperly on healthy skin. But for LS and LP, the steroid is combating a disease that is already thinning and scarring the skin.
So the benefit outweighs the risk.
Not far. We teach patients to use the fingertip unit, or FTU. It's a measured amount that covers the treatment area safely. Long-term compliance is the single most important factor. Stopping the maintenance dose allows the inflammation to creep back and the scarring to progress.
And finally, we have to address the long-term risk associated with these conditions.
Yes, both conditions, but particularly lichen sclerosus, carry a small but measurable increased risk of vulval cancer. It's estimated at between 2 to 4%.
But the treatment helps reduce that risk.
Significantly. Consistent long-term steroid use greatly reduces this risk. But regular monitoring by a specialist looking for any non-healing sores, thickening, or abnormal patches is vital, even when symptoms are well controlled.
So we have atrophy from hormones, and we have inflammation from skin conditions. Now let's turn to the muscle and nerve factors, which often persist even after the tissue itself is healed.
This brings us squarely back to that biopsychosocial loop, where previous pain, stress, or even just anticipation creates a neurological reaction that becomes a physical problem.
And this is where we see pelvic floor hypertonicity or spasm.
Exactly.
Define the guarding reflex for us. How does the body translate anxiety into deep physical pain?
It's a primitive protective response. Imagine you're about to be hit, you brace for impact. The pelvic floor muscles form a supportive hammock at the base of your pelvis.
Okay.
If you experience pain or trauma or even just consistent stress and anxiety, the brain learns to anticipate pain and instructs those muscles to clench. That is the guarding reflex.
And over time, that becomes a habit.
It becomes the default setting. This chronic tension causes the muscles to become tight, short, ischemic, which means they lack good blood flow and they get riddled with trigger points. The nervous system becomes wired to maintain this hypertonicity.
And the resulting pain is that deep, persistent ache, correct?
Exactly. It causes a deep aching, pressure, or throbbing. And the hallmark symptom here, which differentiates it from friction pain, is that the pain often lingers and worsens after sex.
Why is that?
Because the muscles were activated during penetration and then they just remain in spasm, creating a sensation of being internally bruised or having deep cramps for hours or even days afterwards.
Now let's detail the two major nerve pain conditions we mentioned earlier, starting with provoked vestibulodynia, or PVD.
PVD is a form of localized vulvodynia. The pain is specific, it's localized, and it's sharp. It is literally confined to the vaginal entrance, the vestibule, and is triggered by specific pressure.
Like insertion.
Insertion, tampon use, even tight clothing, or sitting on a bike seat. The critical factor is that the skin looks entirely normal, but the nerves that transmit sensation in that area are hypersensitive. They're misfiring, translating light touch into intense burning or stinging.
And the deeper nerve pain, pudendal neuralgia or PN. Why is this one often so difficult for general practitioners to pin down?
Because it's a nerve entrapment or irritation issue, so scans like ultrasound or an MRI are almost always completely clear.
So you have to rely on the story.
We rely heavily on the clinical history, specifically using the Nantes criteria, which are the international guidelines for diagnosis. If we suspect PN, we look for 5 core features.
Okay, walk us through those 5 criteria.
1. The pain must be in the anatomical region of the nerve, which is the saddle area, so the genitals, perineum, or anus.
Right.
2. The pain must be significantly and consistently worsened by sitting. This is a huge one.
So sitting makes it worse.
Dramatically worse, which leads to number 3. The pain must be relieved when the patient is standing or lying down or sitting on a donut cushion.
And number 4.
It causes no objective sensory loss, meaning you can still feel pinpricks and light touch normally. The nerve is sending pain signals, not failing to send any signals.
And the final one.
And 5, crucially, a diagnostic injection, a nerve block, must temporarily relieve the pain. If a patient meets these criteria, especially that sitting rule, the diagnosis becomes highly probable. We also note that unlike acute inflammatory pain, PN usually does not wake a patient from their sleep.
That robust diagnostic pathway leads us to a really complex set of root causes. But sometimes, even when we treat the GSM or we start pelvic floor physio, symptoms persist.
Yes.
Because of external factors we haven't considered, medications and specific lifestyle habits can actively sabotage comfort.
This is a major area of frustration for patients because these factors are so often overlooked. We absolutely must discuss medication-induced sexual dysfunction, particularly around hormonal birth control and psychiatric medications.
Let's start with the pill and what you call the SHBG trap. What is happening physiologically when certain hormonal contraceptives are used?
Okay. The combined oral contraceptive pill, which contains synthetic estrogen, enters the bloodstream and goes straight to the liver on its first pass. This triggers the liver to produce massive amounts of a protein called sex hormone binding globulin, or SHBG.
And what does SHBG do?
It's designed to scavenge and bind excess free sex hormones. Studies have shown SHBG can increase by up to 400% in some women using the pill. And SHBG doesn't just bind estrogen, it aggressively mops up free testosterone.
And why is that loss of free testosterone so detrimental to genital health?
Well, free testosterone is vital for libido, obviously, but it's also crucial for maintaining the density of nerve endings and blood flow in the genital area.
So when it drops,
When free testosterone drops severely, it can cause a secondary thinning of the vaginal entrance and the vestibule. This leads to nerve hypersensitivity, vestibulodynia, and a significant reduction in arousal and clitoral sensation, even in young women. It essentially creates a hormonally depleted state that mimics menopause.
so if a woman is experiencing this, switching methods seems necessary. What are the clinical alternatives that bypass this SHBG spike?
The goal is to avoid the liver's first pass metabolism. That means switching to transdermal methods like the patch or the vaginal ring, or using local delivery systems that contain a progestogen that has minimal binding capacity, and non-hormonal options. If contraception is still needed, non-hormonal options like the copper IUD are excellent, as they have zero systemic hormone impact on this system.
Okay, next, the impact of SSRIs antidepressants, which are incredibly common.
SSRIs, or selective serotonin reuptake inhibitors, are notorious for causing sexual side effects. While they improve mood by increasing serotonin, that same mechanism can dampen the entire sexual response cycle.
How does that manifest?
Frequently as genital anesthesia, or numbing. It makes physical stimulation difficult or sometimes impossible to feel. It also causes difficulty in reaching orgasm, or anorgasmia. This can be devastating for a person trying to manage their depression while still maintaining intimacy.
What's the safety advice regarding SSRIs?
The big one is never stop an SSRI abruptly. That can cause severe withdrawal symptoms. This has to be a structured conversation with the prescriber.
So what are the options?
The patient can discuss switching to antidepressant classes that have a lower sexual side effect profile, like bupropion or mirtazapine, or even just exploring lower dosages.
Are there any other unexpected culprits in the medicine cabinet that contribute to painful dryness?
Yes, often things we don't associate with sexual health at all. Isotretinoin, often sold as Accutane for acne, causes widespread mucosal membrane dryness. That can lead to severe vulval and vaginal fragility.
Wow. And what about allergies?
Older, sedating antihistamines like chlorphenamine, they dry out all mucous membranes, eyes, mouth, and vagina. For patients taking these for allergies, the simple solution is often to switch to a local treatment, like a steroid nasal spray, which treats the allergy locally without causing that systemic drying effect.
Once we've stabilized the medications, we get to the critical foundational support, the self-care that underpins all the other therapies.
This section is paramount. If you skip this, no amount of specialized therapy will work as well as it could.
And it starts with a key distinction.
Yes, we need to clearly differentiate between lubricants and moisturizers, as they are so frequently conflated.
So tell us the difference in function.
Okay, lubricants are for immediate use. They reduce friction during the act of sex. Think of them as oil for the engine. They provide temporary surface relief.
And moisturizers.
Vaginal moisturizers are different. They are tissue treatments. They are typically based on hyaluronic acid, which is a massive water-binding molecule. They must be applied regularly, 2 to 3 times per week, regardless of sexual activity.
So they're treating the underlying issue.
Exactly. They actively bind water to the tissue, restoring baseline hydration and plumpness over time. They're actually treating the atrophy rather than just masking the friction.
Now let's talk about irritant avoidance. The advice you provide here is incredibly practical and often involves things hiding right in the laundry room.
The vulva is made of very delicate, highly absorbent skin. It is not like the skin on your arm. We have to minimize chemical exposure.
So what are the golden rules for the laundry?
3 things. First, use non-biological detergent. The enzymes in biological detergent can be powerful irritants to delicate mucosal skin.
Okay, number 2.
Second, avoid fabric softener entirely. Fabric softeners contain chemicals, particularly quaternary ammonium compounds, designed to coat the fibers. This residue sits directly against the vulva and is a potent source of chronic low-grade irritation.
And number 3.
Always use the extra rinse cycle on your washing machine if you have one, just to be sure all the residue is gone.
And for personal hygiene, what's the simplest rule?
Plain water, that's it. Avoid scented soaps, bubble baths, douches, and wipes. These disrupt the natural pH and the delicate chemical balance of the area.
And there's one really simple, free intervention.
Yes, the recommendation to sleep without underwear or airing out. It minimizes heat, moisture, and potential microbial growth overnight. It can make a huge difference for some people.
Let's move to pacing and positioning. When pain is part of the equation, how do we adjust the act of sex to reduce the risk of pain reinforcement?
We prioritize control and preparation. For deep pain, the most comfortable positions are those that allow the woman to dictate the angle and limit the depth of penetration.
So things like
Women on top or side-lying positions are often recommended as they allow maximum self-regulation. This prevents the abrupt, deep thrusting that can trigger that collision pain.
and you stress the need for a significant preparation time. Why is extended foreplay so important anatomically?
It is entirely physiological. It's not just romantic. When a woman is sexually aroused, a reflex known as vaginal tenting occurs.
Tenting.
Yes. The upper 2/3 of the vagina expands, it lengthens, and the cervix moves up and away, creating a larger reservoir.
But that doesn't happen instantly.
Not at all. This process takes time, typically 15 to 20 minutes of sustained arousal. If penetration occurs before tenting is complete, the vagina is shorter, tighter, and the chance of painful collision with the cervix or friction tears dramatically increases. This is why patience and generous lubricant are non-negotiable.
Finally, communication. Painful sex can isolate couples and introduce so much anxiety. How should partners frame the discussion?
It has to be framed as a team sport, a shared challenge, not a problem owned solely by the woman.
And this needs to happen outside the bedroom.
Absolutely. A low-pressure conversation outside the bedroom reduces the woman's guilt and the partner's feeling of rejection or their fear of causing harm. We often recommend the menu approach.
The menu approach, what does that entail practically?
It involves explicitly agreeing on a range of non-penetrative intimacies beforehand. You create a menu of options that feel good and safe. Things like massage, mutual masturbation, oral sex, cuddling.
And that serves two purposes.
It does. First, it maintains intimacy and connection, which is vital. But second, and crucially, it breaks the fear avoidance cycle. If the couple knows penetration is off the table for a period, that, will this hurt tonight? Dread just disappears. And that automatically relaxes the pelvic floor muscles, which aids in the healing process. Partners are often greatly relieved when they are given clear guidance on what is safe and pleasurable.
So we've built the foundation. Now let's move into the clinical interventions, starting with the cornerstone therapy for those hormonal tissue changes, local hormone therapy.
Vaginal estrogen, in its various low-dose forms, creams, pessaries, or rings, is the consensus first-line treatment for GSM. Its efficacy is high because it targets the root cause, tissue starvation.
So it's rebuilding from the inside out.
Exactly. It rebuilds the vaginal epithelium, it restores the RCOG, those protective folds, it brings back blood flow, and it corrects the pH. It makes the tissue robust enough to withstand friction again.
A major source of anxiety for many women, particularly those with a personal or family history of cancer, is the fear of systemic hormone exposure. How does local estrogen compare to standard oral HRT?
That is a vital distinction. Oral HRT is designed to circulate throughout the entire body to treat hot flashes and other systemic symptoms. Local vaginal estrogen delivers a minute, tiny dose directly to the vaginal tissue.
So the absorption is minimal.
It's often undetectable in the bloodstream. It does not carry the same systemic risks as high-dose oral HRT, and often, even breast cancer survivors, provided they're post-treatment and have clearance from their oncologist, can safely use local vaginal estrogen to restore their tissue health. It's a highly localized repair job.
Now let's discuss the innovative dual action alternative, vaginal DHEA. This seems tailored for women who feel like their sensation or libido is specifically impaired alongside the dryness.
That's its sweet spot. Vaginal DHEA, which is prosterone, marketed as Intrarosa, is a unique pro-hormone. Once it's inserted, it's converted locally within the vaginal cells into two things.
So?
It's converted into estrogen, which handles the hydration and tissue thickness, and critically, it's also converted into testosterone.
Why is that local testosterone component so crucial?
Testosterone is absolutely essential for the density of nerve endings and blood flow, particularly in the vulva and the clitoral area.
And this is something standard estrogen doesn't address as well.
Right. Many women report that standard vaginal estrogen fixes the dryness, but leaves them feeling lubricated but numb. Vaginal DHEA's testosterone component helps rebuild that nerve density, often restoring sensation, arousal response, and improving the overall sensitivity and responsiveness of the genital tissues. It addresses the desire and sensation factors.
So local hormones fix the chemical and structural quality of the tissue. But if the problem is muscle tension or neurological wiring, we need different therapies.
Exactly. We need specialized physical and psychological therapies.
Let's start with pelvic floor physio.
For muscle hypertonicity, that chronic clenching pelvic floor physiotherapy, PFPT, is the treatment of choice. But it has to be delivered by a specialist physiotherapist who's trained in internal work.
And if the diagnosis is tension, the treatment focus is fundamentally different from the standard Kegel regimen that everyone hears about.
Completely different. The focus must be on down training.
What's that?
It's learning relaxation and lengthening techniques, sometimes called reverse Kegels, to release that chronic tension. If the muscles are already tight and in spasm, strengthening them with traditional Kegels is counterproductive. It just increases the pain and spasm.
So what does down training involve?
It involves internal manual therapy to release trigger points, biofeedback training to help you visualize the muscles relaxing, and teaching diaphragmatic breathing to actively relax that hypertonic muscle group.
And we have to manage the expectation around the recovery timeline for both muscle and nerve retraining.
We stress the biological timeline. Tissues take time to respond. For true muscle remodeling and hypertrophy, you need at least 8 to 12 weeks of consistent effort.
But for the nerve-related pain?
For chronic pain conditions like PVD or vaginismus, where we're trying to unlearn a deeply entrenched fear reflex and rewire the nervous system, that process takes significantly longer. Typically 3 to 6 months for the nervous system to truly calm down and accept touch as safe again. Patience and persistence are absolutely mandatory.
This leads us perfectly into the role of psychological therapies. And again, this is not implying the pain is in your head,
Not at all.
but recognizing that the nervous system is central to the pain loop.
Exactly. Psychosexual therapy and mindfulness are vital co-therapies. Pain creates fear. Fear creates muscle tension. Tension creates more pain. It's a vicious, self-perpetuating loop.
And these therapies help you break that loop.
They teach the patient how to manage the neurological component. They teach you how to uncouple the physical sensation from the emotional reaction.
What does that mean in practice?
Instead of reacting with panic to a sensation, you learn to separate the "I feel pressure" from the thought, "This is terrible and dangerous." That immediately reduces the stress response and the subsequent muscle guard.
Now let's turn to the most advanced and, frankly, the most heavily marketed area, regenerative gynecology. We need to dissect these procedures clearly and objectively, based on the available evidence.
Yes. These options generally sit higher up the treatment ladder. They're typically reserved for patients who have failed or have contraindications to first-line treatments like local hormones or physiotherapy.
Let's start with energy-based devices, laser and radiofrequency. What is their mechanism of action?
These devices use thermal energy to create controlled micro-injuries in the vaginal wall. The goal is to stimulate a wound-healing response that results in new collagen production, a thickening of the tissue, and improved blood vessel growth.
So for women who can't use local estrogen,
For women with GSM who can't use local estrogen, some studies suggest they can offer modest symptom improvement.
however, the regulatory status is complex, and for the listener, this is a major safety check they must perform. The NICE guidance is quite cautious here.
It is highly cautious. NICE notes that the evidence supporting the long-term effectiveness and safety of these devices is limited in both quantity and quality.
So they're not routine.
No, they are not recommended as routine first-line treatments. For the patient, the critical check is regulatory compliance.
Explain the difference between UK and US approvals here, as clinics often conflate them.
In the UK and Europe, a device must carry the UKCA or CE marking. This is the regulatory body, the MHRA certification, that attests to the device's safety and effectiveness for a specific indication.
And the indication is key.
It's crucial. Clinics must ensure the device is certified specifically for gynecological health. A massive safety risk we see is clinics using lavers that were only ever approved for dermatology like skin resurfacing on the face and using them off-label on vaginal tissue. This is an unverified, risky procedure that sidesteps necessary safety standards.
Given that the treatments involve creating micro wounds, what is the mandatory recovery period?
There is a required period of pelvic rest, typically 5 to 7 days following each treatment session.
Meaning no sex.
No penetrative sex, no tampons, and avoiding swimming. This rest period is essential to prevent infection in those micro wounds and ensure the thermal channels heal cleanly.
And it's not a one and done treatment.
No. It's typically a series of 3 initial sessions, usually followed by a maintenance top-up every 12 to 18 months as the tissues continue to age.
Finally, let's dissect the injectable therapies. We have 3 distinct goals here: regeneration, hydration, and volume.
Yes, and we must distinguish between these, as the marketing terms like shot or booster can be very confusing.
Start with PRP, the O shot.
PRP, or platelet-rich plasma, involves drawing the patient's own blood, spinning it down in a centrifuge to concentrate the platelets, and then injecting the resulting plasma.
And that plasma is rich in.
It's rich in autologous growth factors like VEGF and PDGF. These factors are meant to promote the regeneration of new blood vessels and nerve tissue.
And the evidence.
The evidence is still growing, especially for generalized sexual dysfunction. It is considered emerging or experimental, but it is showing promise in highly specific tissue repair, such as in cases of Lichen sclerosus scarring.
What's the main challenge with PRP?
The quality of the result is entirely dependent on the quality of the individual patient's blood, which is highly variable.
Okay, what about the newer category of polynucleotides or skin boosters?
Polynucleotides are derived from purified salmon or trout DNA. They act as a specialized scaffold when they're injected.
So what's their mechanism?
It's twofold. They physically trigger the body's cells to regenerate collagen, and they are also highly hygroscopic, meaning they dramatically attract and bind water into the tissue.
So their primary goal is?
Improving tissue hydration and quality for dryness or atrophy. Their advantage over PRP is that the formulation is standardized and consistent. They're injected superficially into the mucosa.
And the third type, fillers, which is often framed as the G-shot or labia majora augmentation.
Fillers use high viscosity, cross-linked hyaluronic acid. Their purpose is purely structural, to add volume and cushion.
So they're not designed to fix atrophy or improve nerve sensitivity.
Not at all. They're used, for instance, to restore the plumpness of the labia majora, which can shrink with age and cause chafing. They may also be used for anterior wall augmentation, the G spot to increase friction or padding.
And the recovery is different.
Yes. Because the gel is thick and needs to settle without migrating, the required abstinence period post-procedure is longer, typically 7 to 14 days.
That journey covers everything from initial location mapping to the latest in tissue repair. So what does this all mean when you synthesize the complexities of dyspareunia?
It means that a solution is almost always possible, but it is rarely simple.
Right.
Painful sex is not a moral failing or just an inconvenience. It is a complex physical symptom. It results from the interaction of structural health hormones, skin neurological signaling, muscle function, and, of course, the emotional brain.
So the most effective route to recovery is always holistic.
It requires a multidisciplinary team, often a specialist clinician, a pelvic physiotherapist, and a psychosexual therapist, all working together.
And for those starting a treatment regimen, you emphasize the 3-month rule. Why is consistency over this specific period so vital?
Because of biology. Whether you are using local estrogen, starting specific downtraining exercises with a physio, or undergoing laser treatment, the body needs time to respond and remodel.
Things don't change overnight.
Not at all. Collagen turnover, hormone receptor upregulation, and muscle memory. They require a minimum of 8 to 12 weeks to show their full effect. Stopping prematurely or reviewing results too early leads to the false conclusion that the treatment has failed. We have to commit to the plan for 3 months before making changes.
Final provocative thought for the listener. Remember the core principle of recovery, especially if chronic anxiety has created that fear-pain cycle.
Yes.
Pausing penetrative sex, if it's medically necessary, does not mean pausing intimacy or neglecting your tissue health.
Crucially, penetration is not the mechanism that maintains tissue health. Blood flow, not penetration, is what maintains vaginal tissue elasticity and health.
So continue everything else.
Continue external stimulation, use your prescribed topical treatments diligently, and maintain non-penetrative intimacy with your partner. By maintaining blood flow and applying local medicine, you allow the tissue the space and time it needs to heal robustly without reinforcing that neurological fear pain loop.